Good morning, everyone. Welcome to Pediatric Grand Rounds. Today is the 15th day after Valentine's Day. Today's speaker is Dr. Aubrey Knight, and let me be very clear, my introduction will in no way do his impressive body of work justice in the last 30 years. He is currently the Professor of Medicine, Family and Community Medicine, and serves as a Senior Dean for Student Affairs at VTCSOM. He's also the Program Director for Geriatric Fellowship. He's a UVA graduate, must be happy they're in the final. Trained right here at Carilion in family practice, went on to do a Geriatric Fellowship and additional training in hospital and palliative care. He has worn many, many hats in the last 30 years in his service to the Roanoke community, including past Program Director of Family Practice, Hospice and Geriatric Programs, Medical Director of multiple organizations in the Valley. He is widely published and has won numerous awards for his teaching and humanitarian services over the years, and is routinely voted one of the top docs in Roanoke Valley, as well as the one with the best bedside manner. Please help me welcome Dr. Aubrey Knight.
Thank you, Dr. Parmeshwar, for that introduction. So a couple of years ago in the Conversations in Ethics series, I gave a talk on boundaries in medical practice, and Sherry Wicker asked me after that talk if I would do something similar but in medical education, and I thought, sure, why not? And began researching that talk and realized that while there's a lot of information about how we are to interact as physicians in that physician-patient relationship and that fiduciary relationship we have with our patients, there's very little, frankly, that in the literature anyway, to guide our understanding of how we interact in our teaching roles. And little in the literature. There are most hospitals have policies related to the interface and the doctor-patient relationship. Less so when you look at the teacher-learner relationship in the context of the hospital. So this was not as easy a talk to prepare, quite frankly. So I did it. I guess it went over okay because I've now been asked not only for pediatrics but for many of the departments to repeat it in the context of their department. I gave this talk at the TEACH seminar last year, right about the time that the 2017 graduate questionnaire from AAMC came out. So the graduates from every medical school's graduates are asked to complete a questionnaire about their 4-year experience in medical school, and the report of that is made available to the schools in the late summer, early fall. And as I'm going to show you in a couple of minutes, this year's GQ had a few surprising and enlightening and concerning results that play into today's talk. So you're going to see those, and hopefully we'll be able to talk through some of them. So this is an Escher, famous Escher painting called Relativity, and I put it up there because, in my view, this is illustrative of the relationship that exists between teachers and learners. Our roles as teachers and evaluators are clear, but we also have roles as mentors to our students, and part of that role is to help socialize them and help them develop their professional identity. In that sense, our students and residents are our colleagues. That means that it's appropriate for us to allow them into our lives to the extent that it aids in their professional identity formation. We all have different reasons why we became teachers. It may have fallen into our laps. We may have purposefully chosen a career that led us down the path of education. But whatever our reason, we have a responsibility to enhance the learning environment and the professional development of our learners. And in doing so, we need to find a balance between caring, closeness, and availability on the one hand, and distance and objectivity on the other hand. And that's where this painting demonstrates that very treacherous nature of that balance, where we might see, wherever we are at that point in time, there's really nothing to worry about, when in fact, looking at the bigger picture, there are dangers that loom. A couple of years ago, there was a internet phenomenon, I guess, or something like that, where you look at this dress and everyone saw a different color to the dress. Was it gold? Was it purple? Was it mostly black? And there was this sense of why do I see it one way and why does someone else see it another way? And I don't have the answer to that question, only that the view of that was in the eye of the beholder. And as we go through this, you're gonna some of the vignettes I present, you're gonna say, really? And others, and some of you will see the same vignette and say, really? It's in the eye of the concerns can be in the eye of the beholder. So I have no financial relationship to any product. I'm going to bring up any product here, but I'm supposed to put that disclosure in there nonetheless. So our objectives today are to describe some of the ethical responsibilities that we have as teachers in maintaining professional boundaries with our trainees, to identify situations in which we might inadvertently probably breach those professional boundaries and provide some guidance that would help us in avoiding some of those violations. And I'm going to do this by presenting a framework, but also in the midst of that, bring up a couple of vignettes that we're going to talk through. So I want some audience participation here as we go, and I'll share with you the questions that we want to consider as we go through those vignettes. But before we get to those, I want to just kind of present a little bit of a framework to you. The AMA provides for us a code of medical ethics, and while most of that is about our relationship with patients and our role as providers, there are some of the terminology that can be translated towards our relationship beyond that. And it defines its code of ethics as the essentials of honorable conduct for physicians as members of the medical profession, and it lays out the foundation for our self-regulation. As a profession, we are self-regulated, and the trust that exists from our patients, and I would argue also from our learners. State medical boards and courts across the country draw on this code. This is what medical boards use as their guidance for reprimanding or not physicians. Boundaries are mutually understood, unspoken physical and emotional limits of that professional relationship between physician and patient, but also, I would suggest, between student and patient and between teacher and learner. The essence of that relationship, whatever that relationship is trust. So even though as I researched the boundaries in the physician-patient relationship, I recognize that clearly is a fiduciary relationship. So too is the relationship between teacher and learner a fiduciary relationship, because the core to it is trust. So we're going to focus the rest of this talk, for the most part, on the teacher-learner relationship. And with that being said, I could have taken this. I decided when I did this the first time in the teach session, I looked at it and thought, well, you know what? I can do this as a physician-patient boundary issues and say this is how we mentor our students and our learners is by the way that we treat our patients. The means in which we maintain our boundaries with our patients can be translated to that teacher-learner relationship. I decided not to do that, and we're not going to talk much about the physician-patient relationship, with one exception, and that is when we are asked to be providers for each other, and how that plays out in those boundary issues. So what is that relationship? So in medical education, and so we need to understand this in order to better kind of frame these vignettes I'm going to talk about. That in medical education, the teacher-learner relationship is a special and unique one, obviously. Involves specialized knowledge and skills, but most importantly has an inherent balance of power, and that's where we have to keep in mind as we go through these vignettes, that as much as we want to be friends with our learners and and draw them into our lives, we have to remember that there is an inherent balance of power differential there. There are external factors that can further contribute to vulnerability as relates to that relationship, whether those are financial stresses, and also excess demands on our part as well as on the part of our learners. Couple policies that I wanted to bring out to you. There is a med-ed policy on fraternization, and Dr. Keyes, if I don't have the most recent one or if any of this is incorrect, make sure correct me here. But the fraternization policy states, or I pulled out a few things from this fraternization policy that state that residents or faculty involved in a romantic or sexual relationship with another resident, medical student, or employee over whom they have supervisory authority or responsibility must immediately disclose that relationship to the appropriate official and must not evaluate the performance of that other person. The Carilion Medical Center may take such action it deems necessary to address the situation. They don't define what that action is, but it says they can take action if once this is disclosed, this relationship is disclosed related to that. A faculty member or resident who fails to comply with this policy is subject to remedial action, and you can read into remedial action, and you're probably correct by reading into remedial action. The faculty handbook, which is now called the faculty bylaws at VTC, we're integrating into Virginia Tech this year, so we're having to change some of our words. We call things handbooks over in the medical school. We're going to call them bylaws when we become Virginia Tech. So the faculty bylaws has a section on unprofessional behavior of a faculty member, and it quotes an intimate relationship occurring in which a faculty member has a direct teaching, supervisory, mentor, or preceptor role and would be making or contributing to an assessment of a student directly contradicts the teacher-learner compact and would be considered mistreatment. An intimate relationship may develop apart from any teaching or supervisory role the faculty member may have over that student. Even if consensual, such behavior is considered unprofessional. So the faculty bylaws makes very clear that nature, the sexual, and this whole talk is not going to be about sexual relationships. It will be about that. We'll talk about that, but it's not only about that. I wanted to point out that the fraternization policy of med-ed and the faculty handbook really only deals with those two components explicitly. Our teacher-learner compact that we have in undergraduate medical education as well as graduate medical education defines responsibilities and commitments of faculty as, first and foremost, treating learners with respect, treating learners and colleagues especially equally without regard to gender, race, disability, cultural origins, race, or religious beliefs, and treating colleagues and patients in a professional manner. And we are committed as faculty to be mentors to our students, colleagues, maintain high professional standards in all of our interactions, respecting our students as individuals without regard to gender, race, national origin, religion, or sexual orientation. And we will not tolerate anyone who manifests disrespect or who expresses biased attitudes towards any student. We sign this teacher-learner compact as faculty that we will abide by the tenets of this compact. There is also a conflict of interest policy that we sign related to our relationship with students, and the LCME is very clear that conflicts of interest need to be identified, and as we go through some of these vignettes, you'll say that in addition to whatever may or may not have been inappropriate, that clearly is a conflict, at a minimum that's a conflict of interest that ought to be identified. So what's the big deal? And as I've mentioned previously, the central and most often misunderstood concept, especially as we become closer with our learners, whether they're students or residents, is this imbalance of power. Learners depend on the knowledge, skill, and judgment that we bring, not to mention the assessments and letters of recommendation that we will be providing for them. So we have coercive influences beyond our intentions or beyond even our awareness. So while we may not consider ourselves in any way intentionally coercive, the influences are there because of what our roles are. So finally, we need to be treating all learners fairly and equitably, and that's, you know, that's kind of I don't think there'd be any disagreement that we'd want to say that. However, our actions don't always respond in a way of what we would say. So what are the consequences of crossing barriers, of some of these potential barrier violations? Failure to maintain appropriate boundaries can do any one of a number of things, from compromising professional objectivity and judgment, violating our commitments, the teacher-learner compact, the things that we've signed and committed to as teachers and as physicians, erosion of that neutrality between ourselves and the learner, undermining that trust, that basic trust that exists in that relationship, jeopardizing the quality of medical care. I mean, some of these things can go that far, and you'll see how that can happen. And then, depending on the degree to which this becomes more public knowledge, eroding patient and public trust in us individually and in our profession more globally. Specific consequences, though, for the learners and for us include, you know, for learners, emotional stress, damage to relationships, that the sense that they as the learners were somehow complicit in that boundary being crossed, and the effect that can have on them professionally as well as emotionally. For the physician educators, depending on the nature of those boundary violations, this could be devastating, from loss of our role in education, loss of trust, loss of job, loss of license. It could be personally damaging, damage to our reputation, family, and emotional stress, and then, of course, depending on what it might do to us professionally, could be financially damaging as well. So when there are potential boundary issues, what's the reporting mechanisms? And I'll put this in here, these next couple slides in here, just to make sure everyone's aware that there are proper ways to report that. In the context of the medical school, the first reporting I would suggest would be either anonymously reporting it through the means that our students know how to do, or reporting it to the clerkship director. In the context of graduate medical education, there also are anonymous ways of reporting these kinds of violations, but short of that, there are. You shake your head, but.
No, there are. It just makes it very difficult to deal with when it's anonymous. Then you don't know how to even address it.
Great point. And so I will say, we need to provide the anonymous means of reporting things, I believe. But Dr. Keyes is absolutely right that when there are anonymous reports, it is very difficult to know how to deal with it and how to rightly address it. But with that being said, the students and residents and learners alike need to have that ability to report things anonymously because of that imbalance of power. So within the context of graduate medical education, the residency director, if this were a junior faculty, senior faculty issue, the chair, and then when there are potential boundary issues that are not reportable but exist nonetheless, then identifying them as conflicts of interests are ways to, if you will, report. There are internal and external chains of commands that are required, and sometimes these things are or must be reported to the state medical licensing boards. Most states require, as a condition of licensure, that we formally report to the state board when we have reasonable basis to believe that a licensee has violated any of the board's regulations. We as licensed providers, physicians or otherwise, we are bound to, when we have reasonable evidence to suggest that, to report that. And hard as that might be, it is still our responsibility, and we're supposed to do that. So what will the state medical board then do? So they have at their disposal a broad range of sanctions, from revocation of license, suspension, depending on what it is, revocation of controlled substance license, probation, restriction of license, reprimand, education, enrollment in an impaired physician program, a lot of things at their disposal. We get a report from the Board of Medicine every quarter that lists all the providers across the state that have been brought before the Board of Medicine, and unfortunately that's a relatively lengthy document that is relatively small type. There are a lot of providers that are brought before the state medical board, and many of them are professionalism issues, not necessarily professional boundary issues in the strictest sense, but many of them are professionalism issues and not necessarily poor medical practice or poor choices in their medical practice, but rather professionalism. Many states also criminalize various sexual boundary violations. Okay, so with all that as the backdrop, let's talk about what are some of the potential boundary problems that we have, and I'll present a few of them as we go along. From overfamiliarity and preferential treatment, or the sense of overfamiliarity, preferential treatment, inappropriate physical contact, harassment, mistreatment, providing medical treatment to learners, communicating religious or political opinions to learners, soliciting charitable contributions from learners, business rights and gifts, digital communications, all these things at one level can be considered boundary violations. You look at them and say, huh, and I'll help define that for you in a second. So here we go. What we're gonna do as we go through some of these vignettes is we're gonna ask ourselves and maybe talk through, is something like this ever appropriate? Is it a boundary issue per se? Is it mistreatment? Do age, gender, race, or other factor play into the appropriateness or inappropriateness of that violation? Because that helps define whether it's a boundary violation anyway. What might others think? What will it matter? And what action should be taken? So try to remember those questions. I've got them written down here so I won't forget them. And we'll go through some of these vignettes and look at them. So the first one is a surgery clerkship director invites the male students rotating on the service to play a round of golf with him. The female students are not invited. Boundary violation? Is this ever appropriate?
I guess is the first question.
Yeah, is this ever appropriate? So I see mainly no shaking heads. I think you know, the way it's described here, I would say no, because it says invited. It doesn't say just played. It doesn't say that he invited all of the students and as it turns out, only the male students wanted to play. That would be a little bit of a different scenario. This says invited. So probably not appropriate. Is it a boundary issue? Yeah, I think by the way we've defined it, I would say it is. This is gender played a role, presumably, in this invitation and in this outside the hospital setting going. This outside the hospital event happening, and potentially resulted in preferential treatment. Nothing to say that that's going to happen, but the potential exists. What action?
Aubrey, were you saying it would be okay if he said, hey, I'm playing golf this weekend, if anybody wants to come? Is that okay?
Absolutely, I think it is, yeah. And if
the distinction is because he invited just to in.
Exactly. That would be my interpretation of this. Anybody disagree with that? That he on Friday afternoon he says to the whole team, everybody's there. I'm playing a round of golf tomorrow. Who wants to come with me? And or just show up and we're going to play. And as it turns out, only the guy showed up. I would say that's not a boundary violation. Does anyone disagree with that? No one's willing to say so. So, second vignette, an attending physician tells one of his female fellows about the hormonal shifts that his wife is having in the first trimester of pregnancy, saying that she is not behaving normally or rationally. Boundary violation? Is it ever appropriate? So I guess this could be maternal fetal medicine fellowship, and maybe, no. Okay. So what do you think? I'd say it's a little bit TMI. Maybe not a boundary violation per se. It's probably, you know, a little bit too much information being shared with a learner or with a colleague, period. Any other suggestions on that? These are all things that actually happened and were reported. So that means that someone thought this was inappropriate, because these were all reported, not here. These were all, some of them are here, but these are not all here. But they all are all reported. Okay, I said we would talk a little bit about sexual boundary issues because I think those are some of the ones that maybe concern us the most. So I want to, and I'm also the person who oversees the Title IX program at VTC, so it is my responsibility to make sure that students, staff, and faculty all know what Title IX is and know what Title IX entails. So sexual boundary issues. Sexual impropriety would be gestures, expressions that are sexually demeaning or demonstrating a lack of respect for a learner's privacy. Sexual transgressions or inappropriate touching that are of a sexual nature. And a sexual violation is a physical act of sex. Any of these can create an intimidating, hostile, or offensive work or academic environment. Does everyone agree with that? Is that controversial in any way? Sexual impropriety. Here's the next vignette. A female student who's on a rotation, and the male resident on that rotation, who may or may not be filling out an evaluation of her, shares pornographic material with the student, and then asks some highly personal questions of that student. Is that a boundary violation? Is that inappropriate? Yeah, the heads are shaking like, oh my goodness, fall off here. The student takes no action for fear of negative effects on her evaluation. This is the reason that Title IX has taken on such a big role in educational institutions, is because of this fear of reporting and fear of what the effect of reporting will have in whether it's college campuses or medical school campuses. Sexual harassment, so that would be sexual impropriety. Sexual harassment is unwanted or repeated verbal, or that should be or, physical advances, derogatory comments or sexually explicit remarks, and sexually discriminating comments, which result in the recipient being offended or humiliated and perceiving or fearing that the performance or assessment will suffer. Okay? The AMA holds that sexual harassment between supervisors and trainees is unethical and defines, so this is one of those areas where the AMA does specifically carve out the teacher-learner relationship when it comes to sexual harassment. So that it defines, and this is a quote, sexual advances, requests for sexual favors, or other verbal or physical conduct of a sexual nature when such conduct creates a hostile or offensive academic environment, or accepting or rejecting such conduct affects or may be perceived to affect academic evaluations. That previous vignette was sexual harassment. Because of its nature, but also because there was the perception, and this student did not report it because of the perception that this may have affected a evaluation. At its core, so those of you who are as old as me know when Title IX was created, it was really about athletics. It was because there was a gender inequality related to the athletic teams and the support for, the number of opportunities for women versus men in athletics. But it didn't specify athletics. It was basically gender inequality. And so Title IX has expanded to include these kinds of perceptions of inequality on the part of gender with education. So this particular vignette is a Title IX had it been reported, would have been a Title IX violation that would have potentially resulted or probably resulted in some kind of action against that resident because of its very nature, because my understanding anyway of the ways in which the questions were asked had not only had a sexual nature to them, but what was related to gender and not just related to sex. So I forgot I had this slide in here. Title IX basically states that no person in the United States shall, on the basis of sex, be excluded from participation in, denied the benefits of, or be subjected to discrimination under any educational program or activity receiving federal financial aid. So again, it applies to non-discrimination, program equity, as well as sexual harassment and assault. And we are all responsible employees. So if we have any, if we recognize that the potential exists for there being a Title IX violation, we are supposed to report that. Our responsibility as responsible employees is to report that. Faculty members, residents are considered responsible. Okay, so what about, Dr. Keith has another comment.
I do have a question. So if you go back to that slide, I'm just curious. It says educational institutions that receive federal financial aid. Obviously, that's the medical school. The GME is an educational enterprise, and we receive Medicare money, but does GME fall under Title IX? I don't know the answer to that.
So that's an interesting question. 6 months ago, I would have said no. But there is a case in Pennsylvania that has gone to the Pennsylvania Supreme Court in which a resident charged sexual harassment. I don't know the details of exactly what happened, but the Pennsylvania Supreme Court is defining residents as educational, as learners, and hospitals, because they receive Medicare money. They're not receiving federal money under Title IV, but they are receiving Medicare money and define that as a Title IX violation. The first time that's ever happened. And it's still, it's not been completely defined yet. But the sense is that we may be entering a new world for resident education as it pertains to Title IX. I have to do yearly Title IX training, and it was just 2 weeks ago that I was there, and this case had just come up, and there was a lot of discussion around it from people who, most everyone in that group were undergraduate education, but those of us who were in medical education, and there were a handful of us, kind of talked through that particular case and what the implications might be for graduate medical education. So what about sexual relations between supervisors and trainees? And you know, I think we all can think through stories of all of us that are old enough can think through stories that have happened over the course of years where things like this have occurred. There are obviously a wide range of consensual relationships possible. I'm not telling you anything you don't already know. But remember, such relationships do raise ethical concerns because of the imbalance of power that exists. Is that a consensual relationship truly a consensual relationship? Is it truly mutual consent? And so it calls into nature that very consensual nature of the relationship. So such relationships have a potential for sexual exploitation despite potentially or probably being voluntary in nature. In 2005, the AAMC survey on graduating medical students this is the national data. 4.7 said that they were 4.7 of the students nationally said they were subjected to sexual advances by school personnel, and that actually has been a trend downward over the course of the previous 10 years, I guess, as that slide. However, in VTC that year, 12.1% of VTC graduates reported unwanted sexual advances by school personnel. I'm going to show you more recent data in a minute. I pointed that one out because the difference was so great. The difference has not been that great since then. This was hopefully a one-year blip, but real. These are reported. So what about what other studies are out there? And there really are not a lot, quite frankly. This is a study looking at clinical psychology students and the potential for involvement in sexual relationships with their supervisors. 47% perceived a time of sexual contact in a relationship that created professional and ethical problems. 51 perceived some hindrance to the working relationship at the time of that sexual contact. So if a supervisor and trainee wish to pursue, and this is me, this is not in quotes, wish to pursue a relationship, I would suggest that supervisory role needs to be terminated. I think that makes absolute sense. That's the fraternization policy here at Carilion says that. Even consensual sexual relationships between a medical trainee and a supervisor without a reporting relationship, in my view, brings up ethical concerns, even when that reporting relationship is gone. I think, yes, the reporting relationship needs to be ended, but even beyond that, there remain problems. But you say to me, but we're both consenting adults. The AMA Code of Ethics further states that if parties wish to pursue a personal relationship when a supervisor to trainee hierarchy exists, such a hierarchy should be eliminated before beginning the relationship. So even when consensual, these relationships are inappropriate, in my view, for the following reasons: the potential exploitation, given the inherent inequities of status and power, the potential for antagonism that may develop after the breakup, if there is a breakup, the hostile work environment that can be claimed by favoritism or gender-based discrimination that can exist when those things happen. Again, I'm old enough to know, to have been around when some of these circumstances have happened at various places, and I know that each one of these three things happened, even when the relationship was consensual. Okay, enough about sex. Other forms of mistreatment that are related to potential sexual harassment: favoritism, sexist or racist jokes or slurs, malicious gossip, denial of opportunities, or poor evaluations based on gender. All of those things can be Title IX violations, or are potentially reportable under Title IX. So here is last year's graduate questionnaire. Not all of it, obviously, it's like 80 pages long. But here are some things that pertain to this particular talk based on last year's graduate questionnaire. 5.6 of last year's graduate said they were required to perform personal services. 13.9 said they were subjected to offensive or sexist remarks or names. 5.6 subjected to unwanted sexual advances. 2.8% asked to exchange sexual favors for grades. So this is a 5-point Likert scale, and these two, and the first three are basically say this isn't happening, and the last two say it's happened occasionally or frequently, and these are in the last two columns of that survey. Denied opportunities for training or rewards based on gender, or received lower evaluations based on gender. 8.4 and 5.7% of students were reported that was the case for them. This was obviously very concerning for us, and such that we have taken it to the clerkship directors, to the chairs, to each department, and said we cannot continue to have numbers like this, and we need to figure out where they came from. And what awareness does not exist among our faculty. What about residents? So this is a survey from 2005, so this is relatively old, but I've not found any more recent data on supervisor-trainee relationship boundaries in medical education as pertain to residents. 31.9% of residents who answered this particular questionnaire said that they witnessed favoritism within their residency program, one resident to another. It's not necessarily gender-based, but did witness favoritism. 31% were made to feel uncomfortable due to violations in their personal space. 26% said they were aware of a faculty member dating another trainee. 24% were made to feel uncomfortable by asking details of their private life. 12.1% said a faculty member touched them inappropriately. 10.3% faculty member engaged in a relationship with another trainee which interfered with the learning environment. And 7.7% said a faculty member has asked them on a date. Pretty high numbers, I would suggest. Okay. Any questions on Title IX, on sexual harassment, sexual inappropriateness, sexual boundaries, before we move on to the other ones? Okay. What about providing medical care to learners? So I would suggest to you that it is a privilege and a sign of respect to be asked to be the personal physician of another doctor or person in the medical profession. It's true. But it does create a dual relationship. It does create some discomfort. I can tell you that personally, but it just does. So as with family, we've got to be careful about that objectivity and make sure that we're providing high-quality care, that we're providing appropriate high-quality care, because these relationships can pose the risk of influencing objectivity and clinical and that very relationship. So we need to make sure we have a clear delineation of our roles and a documentation of that bona fide relationship. So a stairwell. Can I have a prescription? Would you send me a prescription for Tamiflu, because I'm pretty sure I saw a patient today who had the flu. That is not a bona fide patient-physician relationship. If you are their doctor and you can do that in the context of a bona fide relationship, absolutely. But short of that, that is not a bona fide doctor-patient relationship and should not occur. Confidentiality, of course, needs to be maintained. And when this happens and it's between a learner and a teacher, a conflict of interest needs to be identified, because you're not just a learner-teacher anymore. You're a doctor-patient and a learner-teacher, okay? The American College of Physicians, the General Medical Council of Great Britain, as well as multiple other organizations caution against us providing care to people that we have another relationship with. And the AMA Code of Ethics states physicians generally should not treat themselves or their immediate families. William was quoted as saying, the physician treats himself as a fool for a patient. There are some surveys, I think I have a slide on that, of the frequency with which we do end up treating ourselves. So every time we go to CVS and get Mucinex for our cough, we're treating ourselves, right? So there is a line at which treating ourselves is appropriate. I mean, we have our patients treat themselves, for crying out loud, and they don't have a medical degree. There is a point at which it is appropriate to treat yourself. There's also a point at which it's inappropriate to treat yourself. And I will tell you that on that quarterly list of medical board reprimands, there are always a few of them wherein a provider gave themselves a scheduled prescription appropriately or inappropriately. I would argue not appropriately. Here we go. Data on treating family and 85% of physicians have treated an immediate family member, significant other, or close friend. That's from a survey in 2006. 88% of surgeons reported that they would operate on their spouse or other family member, and 84% reported they already had. 76% of studies from 1999 to 2009, more than 50% of physicians and medical students reported self-treatment. Now, again, I don't know the details of what self-treatment. Does that mean going to the CVS and getting guaifenesin? Maybe. I didn't look at these closely enough to see how they define self-treatment. But remember that dual relationship. So when you're asked to treat a colleague, just be sure you keep that as clean as you possibly can, documenting it, and create a bona fide relationship. I'm aware of a mid-level provider right now who was asked to do something from someone that they were working for outside of a bona fide relationship that has been reported, and that's not a good thing, obviously. Okay, so what about some other things related to boundary violations? So we're going to go through a couple of more vignettes. So around the middle of a rotation, an attending physician asks a medical student to join his family for dinner at home, and as they sit down, the physician asks the student to give thanks. Ever appropriate? I mean, I would say, so this one doesn't give you enough information. It may be that they attend the same church, and in fact, that might make it appropriate from the standpoint of what this is trying to say. This may not be appropriate anyway because of that potential for preferential treatment, right? But I think that the point of this vignette is the whole religion aspect to it. So I think, could it ever be appropriate? Yeah. Just at this level, is it appropriate? Probably not.
What about,
what about if you flip that? If, say, I give thanks on my own in front of others?
So good question. So you have you have one student or a group of students who are joining you, and as a part of that meal, I'm assuming it is your practice to give thanks, and you do. Is that a violation? I would say no. I would say that you would personally. I would, before doing that, just say this is what we do in our home. I don't mean to be offensive, but this is what we do in our home, and we're gonna give thanks for this meal before doing it. But I would not suggest that would necessarily be a boundary violation.
I had a question, and it may be somewhat cultural. So in the Caribbean, at the end of most rotations, we used to go out as a group, students, residents, attending. Of course, the attending paid. They have no money. Is that inappropriate in this context? For
the attending to pay? No, absolutely not. No. No, I think I would say that as long as the welcome is extended to everyone, that would make it appropriate. If there were any sense of preferential treatment, that would be inappropriate. So communicating political opinions to learners. In our conversations, and especially in this day and time, it's hard not to have conversations around what's happening in the world, right? So I don't think that by itself is any kind of a boundary violation. I think we do need to be cautious of anything that would appear to be offensive, however that conversation went on, and try to stay as aware of nonverbals that are going on in the audience or in that group related to whatever is talked about. But again, recognizing degrees of comfort, power differentials, desires for privacy, and rights to disagree. Soliciting charitable contributions from learners. What about that? What about asking a learner to support a cause that you feel passionate about. I personally would say that's inappropriate. Again, power differential. Think power differential here. It would be hard for a learner to, even with no money, to say no to that harder to say no to that kind of thing. What about a learner asking us to support a cause that they feel passionate about? Students. The power is here, so right, the money is here, right? So, so here's a couple of vignettes. Again, these are all true. Yes.
Sorry, just to, what about attendings who are supporting their kids in like Girl Scout cookies, and then soliciting other residents or medical students, seeing if they would like to buy any Girl Scout cookies? I mean, I'm just.
Yeah, that's a great question, and it's Girl Scout cookie time, and I love Girl Scout cookies. Does anyone have any, by the way? I think a one-on-one, so for me to sign up to buy Girl Scout cookies for my daughter, I would say that would be inappropriate. To say my daughter's in Girl Scouts and it's cookie time, anyone who wants to buy Girl Scout cookies, come see me. I would have no problem with that. I would think that would not be ethically or inappropriate whatsoever. Does that make sense?
Hang on.
Policy is you can leave the Girl Scout cookie.
I'm pretty sure that Carilion's policy is you can leave the Girl Scout cookie sign up in the break room, and anybody that wants to can sign up, but I'm pretty sure you can't approach anybody else more directly.
Okay, thank you. All right, an attending physician has an ownership stake in an urgent care center. There's an urgent need for coverage, and the attending asks the resident to work. The resident declines, claiming that the hours would take him over his duty hour limit. The attending assures him that the hours will be off the record. Dr. Keys, this was not here. This was not here. So that's a violation on a couple of fronts, right? It's a duty hours violation, but I think this is also a boundary violation. This is an attending who has a power differential and a resident who, money or no money, there's you know, he's not only offering him the availability to work, he's telling this resident that, you know, this is going to be okay because I'm going to make it right.
So he's also creating a lack of integrity. So, I mean, he's creating that environment, which is totally wrong.
Exactly. Thank you, Dr. Keys. Clerkship faculty asks to house sit for the weekend while she and her family are away, or away. Boundary violation? Yeah, I think it is. I think it's it creates a potential preferential treatment, and so I would suggest to you that this particular student who's being asked to house sit would not see it that way, but fellow students who knew about this happening would be concerned about how that played out and what that might have meant to them. What about gifts? What about teacher-learner gifts in both directions, actually? I think you got to be careful of them. As with gifts from patients, you know, that there are some AMA Code of Ethics guidance on gifts from patients. I think these are circumstances that are nuanced, and there's probably no universally right or wrong answer, but care needs to be taken for sure. Digital communications, again, real story. Residence director hosts a holiday party. One of the residents who is invited takes and posts a picture that is subsequently misinterpreted to represent an inappropriate relationship, creating a hostile workplace that ultimately leads to the residency director having to step down. The picture did not exhibit exactly what was going on, but it was interpreted that way. And it created, the residency director was not forced to step down over an inappropriate relationship or an inappropriate, that behavior being inappropriate. He had to step down because the work environment became hostile and could not continue. So care with digital communications. So again, I'm going to conclude by saying that any teacher-learner relationship in medical education is about finding the balance between closeness that's necessary for good mentoring and distance that allows for that teacher to perform their function without coercing the student into engaging into activities that may either be academically or psychologically harmful. We need to keep that in mind and remember that imbalance of power in every situation that we may find ourselves in. Thank you. Are there questions? Yes, sir.
I don't know if everybody knows who Alan Alda is. He was an actor in the TV show MASH, but he gave a speech in, I think it was like 1979 at Columbia Medical School to the graduating class, and it's neat because he talks about the relationship between, physicians and their patients, physicians and physicians, and even gets into a little bit of, the Title IX between, male and female physician relationship, and it's kind of neat because that was in the 1970s, and we're still talking about it today, but it really is an inspiring speech, and would recommend it to everybody here.
That's 30 years ago, and we're still dealing with some of those issues. Dr. Keyes.
I'll try to keep it brief. Thank you so much for this. This is really helpful. I'm always interested in the collision of things, and this, to me, collides, in a sense, with wellness. With wellness, we're trying to create an environment that's friendly, that's open, and I fear so many times, because some of this stuff is nuanced in perception, right? So what an action for one person might be perceived as inappropriate, for the other person it may not be. And I'll say personally that I begin to think a lot more about what comes out of my mouth and even what I say or touch, or it's making me a little bit more nervous to even be around publicly. So again, great talk, great reminder, and clearly there are some of the things you mentioned were clearly over the top, but we are in a world that we need to have friends and be able to share our life story, and it makes me a little nervous, I think.
And that's one of the reasons and you noticed I had my glasses on, so I made sure I read that first thing that I wrote, because I wanted to say it right. I wanted for us to not think that this relationship needs to be so separate, and so that we not mentor, that we are teachers and evaluators only, and such that we don't let our learners into our lives and we don't get into the lives of our learners. That's a mistake. And I think that will, if that were the case, lead to more, especially among educators, more burnout, because one of the joys of teaching is not just teaching and not just evaluating. Those are the burdens of teaching. It's getting into the lives of our learners and experiencing with them the amazing profession of medicine, helping them to see that. And if we were to completely separate that, I think there would be more burnout among teachers, and there would be less effective education for our learners. So we've got to somehow merge the two, but care needs to be taken in merging the two.
Yeah, I'm one of the pediatric residents here. I've noticed, like Dr. Key said, it is an interesting collision of both wellness and, almost prevention, if you will. There's a lot of focus on defense, right? Not tripping up, not messing up. And I try to draw the parallel between patient care, right? Of course, we don't want to have any medical errors ever. We would love to treat our patients well and never have mistakes, but unfortunately, there's always a human element involved. So there are going to be mistakes. And so I think the shift from trying to avoid medical errors, we're going that next step and saying, okay, when we make errors, how do we respond? What do we do? How do we heal that relationship? And I think that I'm not seeing that as much. There seems to be more, you know, how do we avoid all these situations, right? Okay, now we're all walking in line, everybody's, you know, lockstep, nobody's stepping out of bounds, but unfortunately it still happens, right? Alan Alda was talking about it in 1970, and here we are. So I wonder, how is this dealt with in corporate America and other places? Where is the focus on, you know, healing those relationships kind of after the fact?
I think I don't know the answer to your question, but I can tell you that corporate America is obviously, I mean, you can't not recognize this. It's all over the news, dealing with these kinds of things and having to deal with these kinds of things right now. But it's real, and it needs to. Your comments are exactly right. You know, we run the risk of robotically kind of getting into this mindset of this is how I'm going to do this, so as to be, in our case, be the teacher and not be the friend. When I believe that is to our peril and to our learners' peril. Thank you very much.
If you are still on the line, sorry we ran out of time to update the phones, but you can always email me at outreach@carillionclinic.org, and I can get them to Dr. Knight. With that, we're going to disconnect the phone lines now. Join us again next Thursday.